Good morning. It's a real pleasure to be here at the Texas Heart Institute Global Cardiovascular Forum. This is now our third year, and I look forward to adding some more about the innovations in the management of thoracic aortic disease. The objectives today will be to review the evolution of open surgical treatment, to discuss our experience with both endovascular and hybrid arch replacement, and to review a couple of complex case scenarios of open and endovascular complications. The anatomy of the aortic arch is now been separated into different zones to help us with our vocabulary and discussing our approach with others. Zone 0 is essentially the ascending aorta. Zone 1 and 2 is the arch. Zone 3 essentially is beyond the arch. The AATS, the American Association for Thoracic Surgery, wrote an expert consensus document looking at the approaches for arch repair in dissections. And in this document, they came up with recommendations that arch replacement is reasonable in patients who have a primary entry tear in the arch, who have brain or peripheral malperfusion, or in whom the arch or descending thoracic aorta is aneurysmal or ruptured. More elective approaches towards the arch are probably reserved for centers that are focused in aortic disease. The ACC and AHA guidelines for aortic arch aneurysm also came out just within the last year or so, and they also addressed reasons to treat the arch. And essentially it's in patients with arch aneurysms who have symptoms, obviously, also those who have arches that are 5.5 or some people say 6 centimeters in size should be considered for arch replacement. So over the years, as we've been more successful with treating type A aortic dissections emergently, we've now got a new patient population of patients that have developed aneurysms in the arch as a long-term sequelae. So open surgical repair strategies, obviously there's hemi-arch replacement, and that's generally what we do in an acute type A aortic dissection. This requires a circulatory arrest approach. En bloc replacement was historically the original way to do arch replacement. There are technical limitations that make this quite complex to perform, however. And so there have been modifications. Various multi-branch grafts have been used to reimplant the head vessels, and there's multiple perturbations of this approach. So if you need to replace the arch and the descending replacement aorta, there's been descriptions of a one-stage approach, which is quite a large operation in which the ascending aorta, arch, and descending aorta are replaced at one time. This, however, can be quite morbid, and that's why we started to look at other sort of endovascular approaches that we could use to address the arch. So our question was, is there a lesser invasive approach? Let's look at case number 1. It's a distal arch dissection. It's a 62-year-old gentleman, acute back pain. He had connective tissue disorder, possibly, but it was not defined. He had a type B dissection that was limited to descending aorta, measured at 4.2 centimeters. He was treated with anti-impulse therapy and discharged home. 3 weeks later, he had recurrent pain, elevated lactate, and his descending aorta had increased to 5.7 centimeters. Here is his preoperative CT scan. The red arrow demonstrates where the left subclavian artery is, very close to the aneurysmal portion of the aorta. Here's the flap present in the descending aorta, and as we go down farther, you can see that the false lumen thrombosis, and we have a normal aorta at the level of the diaphragm. So this patient has, looking at the indications for the STS and AATS clinical practice guidelines for type B dissection, he's got 5 of the indications. 1, refractory pain, increase the aortic diameter, readmission, false lumen diameter greater than 22 millimeters, and malperfusion. So he had multiple indications for surgery. And with a possible connective tissue disorder, open surgical repair is reasonable and probably more appropriate than a stent graft, which can injure the intima. But in this particular case, we felt the patient needed a hybrid type approach. Our plan was to perform an internal elephant trunk, opening the aorta and sewing a graft within the aorta, and then placing an endovascular stent graft through antegrade to complete the resection or exclusion of the aneurysm down to the descending aorta. So here we have a live video showing the ascending aorta. You can see the tape is around the innominate artery up top, and we also have the carotid artery encircled in this particular case. Generally we can do a carotid subclavian bypass ahead of time, so we don't have to reimplant or address the subclavian, and can put our graft at zone 2 instead of zone 3. Here we are clamping the aorta, giving cardioplegia to arrest the heart as we're about to enter in to the aorta, which will require antegrade cerebral perfusion. So next thing we've done is we're going to remove the clamp. We are going to open the aorta, and we put clamps on the carotid and innominate artery up towards the head. We're going to open the aorta, visualize within, expose, put in some retention stitches so we can see within the aorta so that we can replace that segment of the aorta. We're going to pull this aorta apart for exposure. And then the graft is going to be positioned. We now have the graft. We're marking the distal end so we'll be able to see it easily. On X-ray guidance, we generally make this about 5 to 7 centimeters in length. And then we're going to take that marked end and dunk it into the distal aorta, and then we're going to suture the proximal end in order to secure that graft in place. And we're going to use that essentially as our proximal landing zone. Since the carotid was, or the subclavian was so close, we could not really at that time, there was no device available to replace the aorta with an endovascular only approach. And here we're tying down the suture and have completed that proximal anastomosis. Our next maneuver then will be to close the aorta, and we'll put a graft on the ascending aorta through which we're going to perform the stent graft placement as we demonstrate here. So our postoperative or intraoperative angiograms demonstrate the elephant trunk in position with filling of the aneurysmal sac. And you can see that it fills quite large area, but then after placement of the stent graft, we've completely excluded the false lumen. So my history with this procedure is 75 patients, average 64 years of age. Most often chronic dissection is the etiology. In-hospital mortality is reasonable. There is a reintervention rate for dissections that's more substantial than if we do this for an aneurysm only. So the thoraflex was the next step in advancing. This has a built-in stent graft that we can position down the descending aorta as we're replacing the entire arch, as opposed to the patient we just saw. The first series that approved this for the United States was 74 patients that had 1 year freedom from MACE at about 80%, which is quite good. Here's an example of a patient who's got an aneurysm that extends in the arch into the descending, so we need to replace not only the descending as in the first case, but the arch. Here's the Thoraflex. It's loaded onto a delivery system. We use a guide wire to position it down the descending aorta. We're now positioning it and putting the graft down the aorta. It's got a pull string that releases the stent graft. So after pulling out this device, you'll see on the image to the left what's going on. But we've just released the stent graft that's now expanded within the aorta. We take out the retention piece and release the entire system by pulling out a wire, and this will then give us a stent graft down the proximal descending aorta, and which is expanded here by pulling out that device, and you can see the image on the left. So we've now released it, and then after reconstruction of the arch, we can have a complete procedure with arch and descending replacement. So endovascular options I'll finish with. The Gore TBE graft, the thoracic branch device, was the first FDA-approved device for zone 0 to zone 2 indications. It has excellent branch patency of the single branch graft, a reasonable stroke rate, but we have limited experience with zone 0 configuration. This is mainly used to put the side branch into the generally the subclavian arteries, so we can have the stent graft end in zone 2 as opposed to zone 3. The next device is the Cook A branch. 70 patients have undergone. This was only patients that were deemed unfit for open surgery. This graft has branches that go up both head vessels. Also, the Terumo relay branch as well has two branches that go up the head vessels. We've got some experience with this device. We put in 6 personally and 43 around the world. Finally, we've got the Nexus endospan, which requires an open debranching of the arch, and then the single branch graft is placed into the innominate artery, and we can then exclude and replace the entire arch. There's been 28 patients done in the multi-center study. I've done a couple of these patients, and with early results that seem to be promising. Here's a patient, 79-year-old gentleman, had a stent graft up to zone 2. We can see on the preoperative CT scan that the aneurysm and dissection extends into the arch and ascending aorta. So we took him to the operating room and did a angiography that demonstrated the aneurysm sac and aneurysm. We then put the arch stent graft in place with a branch up to the nominate, and we're able to exclude the remainder of the aorta and aneurysmal segments. So before and after, we have complete exclusion of the aneurysm. And finally, the Gore ascending aortic graft is just getting started in the pivotal trial. There's obviously limitations to the ascending aorta in regards to anatomy. So arch reconstruction continues to evolve with novel and emerging hybrid and endovascular treatments. Careful preoperative planning is important, including cannulation and cerebral perfusion strategies. And the surgeons must remain vigilant of the unique complications associated with each type of repair strategy so that we can achieve optimal results. Thank you very much.